Hello, my name is Sarah Pacheco. I am presenting with Lisa Summers and Jessica Wren. Our topic is pulmonary hypertension and pulmonary edema. So for the background of pulmonary hypertension, normal pulmonary circulation is a really low resistance system and the vessels are very compliant. It carries deoxygenated blood from the right side of the heart, oxygenates it in the lungs, and then carries it back to the left side of the heart to be pumped into systemic circulation. Pulmonary hypertension essentially occurs when there's increased pressure in that pulmonary vasculature. It's high blood pressure in the lungs. Pulmonary hypertension is a whole group of disorders, and there are many different causes of pulmonary hypertension. The World Health Organization, or WHO, has 5 classifications of pulmonary hypertension, and each classification is a different cause. So this picture shows the 5 classifications of pulmonary hypertension. Starting on the left-hand side, we have pulmonary artery hypertension. This is a subclassification of pulmonary hypertension. PAH is idiopathic, inherited, drug or toxin induced, such as from methamphetamines. It can be congenital as well. Connective tissue diseases, liver disease, HIV infection, and schistosomiasis. Prevalence of this type of pulmonary hypertension is pretty low, with an estimated 15 to 50 people per million in the US and in Europe. In developing countries, you're more likely to see PAH that's caused by infectious causes from HIV and schistosomiasis. And then another interesting risk factor for this one is young women are more likely to have PAH. The second classification of pulmonary hypertension is caused by left-sided heart disease. This includes, regardless if you have a reduced or preserved ejection fraction, it includes valvular disease such as mitral valve disease, congenital left-sided obstructions or cardiomyopathies. And this is the leading cause of pulmonary hypertension. So there's a lot of people that fall into this category. Next up, the third classification is going to be pulmonary hypertension that is caused by lung diseases, whether they're obstructive or restrictive lung diseases, and also hypoxia. This is the second most common type of pulmonary hypertension. And then the fourth classification is going to be chronic thromboembolic pulmonary hypertension, CTEPH. It's caused by pulmonary embolism in the lungs or embolization of other matter, such as tumor cells. Either way, there's a mechanical obstruction of pulmonary blood flow. A risk factor for this type of pulmonary hypertension is a prior pulmonary embolism. It's a more rare form of pulmonary hypertension with 26 to 39 cases per million adults. The last classification of pulmonary hypertension is that of cases that have an unclear cause, are multifactorial, or have hematologic causes. This includes sarcoidosis, sickle cell disease, myeloproliferative disorders. And again, this is a more rare form, pulmonary hypertension. Depending on what kind of pulmonary hypertension your patient has, their risk factors are going to vary pretty greatly. So for that first classification, we talked about PAH, liver disease, connective tissue disease, certain drug use, whether it be prescribed or something like methamphetamines, HIV, familial history, and young women are all at risk of PAH. Patients with left-sided heart disease are at risk of that second classification of pulmonary hypertension. Patients with lung disease or having an episode of hypoxia are going to be at risk for the third classification of pulmonary hypertension. A patient that has a prior embolism in their lungs is going to be automatically at risk for the fourth classification of pulmonary hypertension. And then some other examples for that last classification of pulmonary hypertension: sickle cell disease is a risk factor, and then sarcoidosis. The clinical manifestations for pulmonary hypertension, your subjective findings that the patient are going to report is going to be dyspnea, shortness of breath with exertion, dizziness, or syncope. As it progresses more, they might develop some chest pain, palpitations, wheezing, and a cough, and then symptoms related to the cause of their pulmonary hypertension. If the cause of their pulmonary hypertension is left-sided heart failure, then they're going to have probably an exacerbation of their heart failure. If it's related to COPD, they might have exacerbated COPD symptoms. So it's important to look at that root cause. Some objective findings that you might discover when looking at your patient, they might have tricuspid or pulmonary regurgitation murmur that's new. They might develop an S3 heart sound and not have advantageous lung sounds, or they might also have advantageous lung sounds. They're going to have increased pulmonic component of that S2 or a splitting of the S2 cardiac sound. You might notice a right ventricular heave, and then they might have signs of a right ventricular heart failure as that blood flow backs up from the pulmonary arteries into the right side of the heart. You might get some systemic backup of blood, such as ascites, JVD, and peripheral edema. Labs and diagnostics you want to look at when you're thinking about a possible diagnosis of pulmonary hypertension. First off, starting with a CBC, you can look at the H&H on this. Elevated H&H could be indicative of hypoxemia. You also want a complete metabolic panel looking at liver and renal function. Patient might have elevated liver enzymes if they have some inflammation in the liver going on or liver disease, hepatitis. You're going to look at the BNP. This might be elevated if it is due to a heart failure cause. You should be tracking it in your heart failure patients as well. You also want to screen for thyroid function. Thyroid disease is common in patients that have pulmonary artery hypertension, and these patients often present with an abrupt deterioration. And then we also, if we don't have a known cause of their pulmonary hypertension, we might want to screen for HIV, hepatitis, connective tissue disease, and coagulopathies, seeing if they're, throwing more clots than normal in the lungs and that's causing it. You also could do some serologic testing for scleroderma and then genetic testing if you think there's a genetic cause to their pulmonary hypertension. As far as diagnostics, one of the most common ones to start with would be an echocardiogram, simply because it's non-invasive and it can give you a high index of suspicion for pulmonary hypertension if you have tricuspid regurgitant jet velocity greater than 2.8 meters per second. Very suspicious for pulmonary hypertension, but not diagnostic. The true diagnostic is going to be your right heart catheterization, and that's your gold standard. When that's done, it is diagnostic. It will clarify the stage of the disease and the subtype of the disease. You're looking for a mean pulmonary artery pressure greater than 20 millimeters of mercury. I know our book lists 25, but a little bit more research literature I saw listed it as 20, greater than 20. You might also want to do some pulmonary function tests if you think that the pulmonary disease is a cause of their hypertension. You could look at a 12-lead EKG. Could show some non-specific findings indicative of pulmonary hypertension, such as right axis deviation, a right bundle branch block, or right ventricular hypertrophy. A chest X-ray could be done, and it might show increased size or narrowing of pulmonary arteries, and a chest CT could be done as well. So for the management of pulmonary hypertension, your non-pharmacologic management interventions are going to include an exercise program. All patients with pulmonary hypertension should have some sort of exercise program, whether it be cardiac rehab or their own program. They should be participating in exercise. It's really important that they're current in all vaccinations, especially your respiratory illnesses. Some patients are going to benefit from supplemental oxygen, and it might help relieve some of their symptoms, or they might need it at night. And then if they have a hematocrit greater than 55%, it'd be reasonable to consider a therapeutic phlebotomy to reduce that. For pharmacologic management, one of the most important things you're going to do for these patients is optimize the treatment of their underlying disease, whether that be heart failure or a pulmonary disease. We really want to make sure that our treatment is zeroed in for those diagnoses. And then in order, pulmonary hypertension is treated by pulmonary vasculature or vasodilation to reduce the pressure. And so one of your first line treatments for that is going to be calcium channel blockers, such as amlodipine or diltiazem. Other treatment options that do a similar thing are going to be your endothelin receptor antagonists, your phosphodiesterase 5 inhibitors, and your prostacyclin analogs. Depending on the classification of pulmonary hypertension, if they're experiencing pulmonary embolisms that are causing that physical obstruction, which then cause the hypertension, you might want to consider some anticoagulation on that patient, might be the treatment. And then diuretics should be considered if you have a patient that's showing a lot of signs of systemic fluid overload to get some of that extra fluid off of them. And then there are some interventional treatment options to consider with patients that would be eligible. These include balloon atrial septostomy and a Potts shunt, which shunts from the left pulmonary artery to the descending aorta. And then in some more extreme cases, you might see heart or lung transplants.
The primary team should collaborate with interprofessional specialty services to treat the underlying cause of the patient's pulmonary hypertension. In some cases, the patient may require invasive interventions in order to assess the extent of the disease process or to initiate certain treatment options. Nursing staff should be educated on what interventions can be completed to help improve the patient's symptoms. Communication with pharmacy should occur to assist with the pharmacological management to ensure the patient is receiving the most benefit from this prescribed treatment option. Respiratory therapy should be involved to assist with oxygenation and ventilation support when necessary. Some forms of pulmonary hypertension are genetic in nature, so consulting a geneticist may be necessary. In rare cases and severe cases, the patient may develop hoarseness from recurrent laryngeal nerve compression, so it may be necessary to have speech therapy evaluate the patient's need for communication needs and swallow evaluation. Finally, in some cases where treatment options are exhausted, it may be necessary to consult palliative care. Pulmonary hypertension is difficult to diagnose in patients older than the age of 65. Oftentimes, when pulmonary hypertension is officially diagnosed in this patient population, it's in the more advanced stages of the disease process. There are a number of disease processes where dyspnea is a primary symptom, and oftentimes providers do not diagnose the patient's pulmonary hypertension, but rather assume and attribute their symptoms are related to one of their other comorbid conditions. When providing patient education, the provider should make sure the patient is aware of the typical symptoms associated with pulmonary hypertension. The provider should recommend lifestyle changes that can reduce their symptoms and potentially slow disease progression. This includes adhering to a low sodium diet, stop smoking, exercising regularly, and avoid things that trigger their symptoms. The provider should also educate the importance of appropriately managing their other comorbid conditions and to keep up with their follow-up appointments. Finally, the provider should educate the patient on when they should seek emergency medical treatment. Signs of cyanosis, worsening shortness of breath, chest pain, and syncope are all reasons to seek emergency medical support. Some patients are sent home on continuous intravenous medications such as Velitri. The provider should explain to these patients that if they run out of medication, their catheter cracks, or their pump malfunctions, they need to seek emergency treatment immediately. The link below provides patient education as well as emergency forms. The provider should refer the patient, if not already established, to a specialist depending on their comorbid conditions. The individual specialist can help appropriately manage the patient's other conditions as well as monitor for secondary injury stemming from the pulmonary hypertension itself. Pulmonary rehabilitation has been shown to be very effective in the patient's treatment plan. This type of rehabilitation can help improve lung function by identifying what treatments work best for the individual patient. Because there is no curative treatment option for this disease, aside from receiving a lung transplant, it's not uncommon for patients to experience depression. So the provider should consider referring the patient to a psychologist or a counselor because this may be beneficial to their long-term care. Finally, depending on the necessary treatment, the patient may need some financial or supportive assistance to coordinate care, so social work or case management may be helpful.
Pulmonary edema disease background. Pulmonary edema is a disorder characterized by fluid accumulation in the lungs caused by extravascular fluid leaking from the pulmonary arteries into the interstitium and the alveoli. This process leads to diminished gas exchange at the alveoli level, progressing to potentially cause respiratory failure, the extent of which fluid accumulation in the interstitium of the lung depends on the balance of the hydrostatic and ionic force with the pulmonary capillaries and the surrounding tissue. Pulmonary edema pathophysiology. Pulmonary edema interferes with gas exchange and the breathing workload. There are two types of pulmonary edema. They are cardiogenic and non-cardiogenic. Cardiogenic versus non-cardiogenic pulmonary edema. Cardiogenic pulmonary edema is fluid in and around the alveoli, increasing pulmonary capillary and negative interstitial pressure, and damaging the alveoli capillary barrier. With non-cardiogenic, the disturbance of the endothelial barrier allows for protein to escape the capillary beds and enhances fluid movement into the lung tissue. Etiology and risk factors of pulmonary edema. Progressively worsening dyspnea, tachypnea, and rales, or also known as crackles, on examination with hypoxia are clinical signs of both cardiogenic and non-cardiogenic pulmonary edema. With cardiogenic edema, it is usually caused by left-sided heart failure, a cough with pink frothy sputum, hypoxemia from alveoli flooding, and auscultation of an S3 gallop could indicate cardiogenic edema. A murmur, elevated jugular venous pressure, and peripheral edema may also point to a cardiac etiology. Non-cardiogenic pulmonary edema is caused by pulmonary injury, symptoms of infection such as fever, cough with expectorant, and dyspnea, suggesting pneumonia, recent trauma, and blood transfusion should be assessed and monitored closely, as these patients may progress to acute respiratory distress syndrome. Clinical manifestations of pulmonary edema. Auscultation assessment in patients with respiratory symptoms noting any fine or coarse crackles is important to determine the next step in the management. Any patient with worsening dyspnea, hypoxemia, tachypnea, S3 gallop, murmur, cough with pink frothy sputum, elevated jugular venous pressure, and peripheral edema should be evaluated for pulmonary and cardiac etiology. Labs for pulmonary edema. We should have the following workup, including a BNP. An elevated BNP level are seen in heart failure patients with left ventricular end diastolic pressure as well as pulmonary occlusion pressure. BNP levels greater than 500 pg/ml suggest a high likelihood of heart failure. An elevated troponin is typically seen in patients with damage to myocytes that can be seen in severe sepsis. Hypoalbumin can be found in patients presenting with acute decompensation heart failure. Obtaining serum electrolyte levels, including renal function, serum osmolarity, and toxicology screening can help identify patients with pulmonary edema due to toxic ingestion or inhalation. Obtaining a lipase and amylase levels help diagnose acute pancreatitis. Imaging for pulmonary edema. Both posterior and lateral views is used for both cardiogenic and non-cardiogenic pulmonary edema. In cardiogenic pulmonary edema, the presence of central edema, pleural effusions, curly B septal lines, parabronchial cuffing, and enlarged heart can be found. An echo can also be helpful in noting heart size and heart dysfunction. In cardiogenic pulmonary edema, the edema pattern is typically patchy and can demonstrate the presence of ground glass, opacity, and consolidation. Using a pulmonary heart cath is the gold standard in determining the etiology of the pulmonary edema. Pulmonary edema management. The first line of treatment for pulmonary edema is to alleviate the symptoms and treat or resolve the underlying condition. Diuretics can be used to remove excess fluid. Using vasodilators like nitroglycerin can help lower preload and pulmonary congestion. Initiating a calcium channel blocker early in treatment can help reduce hospital stays, improve dyspnea, and reduce recurrent hospital ICU admissions. Utilizing oxygen, elevating the head of the bed, and ordering breathing treatments can also help with the symptoms and dyspnea and make the patient feel more comfortable.
The primary provider oftentimes will need to collaborate with specialty services in order to diagnose and treat the underlying cause of the patient's pulmonary edema. There are a variety of medical conditions that can lead to this, and if you don't identify the underlying cause and treat it, the edema can reoccur. It's important for the providers to educate new nursing staff about what can exacerbate symptoms, as well as what new or worsening edema looks like. By providing thorough education to bedside staff who are present with the patient most often, it can help them identify earlier and advocate for interventions earlier to prevent true respiratory decompensation. Collaboration with unit pharmacists should take place to ensure that the pharmacological management of symptoms is appropriate given the patient's past medical history as well as the patient's current medical status. This is also especially important in the geriatric population and those with long-term chronic illnesses where polypharmacy could impact the patient's overall medical progress. Finally, the respiratory therapist can suggest and implement interventions to improve the patient's overall functional respiratory status. While treatment options for geriatric patients are similar to those of a younger age, these patients may respond differently to treatment and alterations in their respiratory system. Naturally, geriatric patients have a lower lung reserve and as a result are more apt to feel the effects of respiratory compromise from the presence of pulmonary edema. This lower reserve can cause the population to have a lower tolerance for hypercarbia or hypoxia. For this reason, these patients may present with respiratory compromise differently than younger patients. Instead of dyspnea or shortness of breath, the patient may experience anxiety, agitation, or confusion. These patients have a difficult time ventilating properly. You may see lethargy or somnolence present more quickly due to their inability to fully clear their CO2. When starting the patient on a diuretic therapy, the provider should consider the patient's current and pre-hospitalization oral intake. If the patient presents dehydrated, conventional diuresis may be ineffective. Additionally, if the patient may be third spacing as a result of hypoalbuminemia from poor nutrition. Finally, the provider must consider the patient's risk for aspiration, which may complicate hospital course if the patient develops aspiration pneumonia. It's important for the providers to properly educate the patient about pulmonary edema. The provider should discuss with the patient about what pulmonary edema is and why it's occurring based on their specific situation. The practitioner should explain the symptoms of acute and chronic pulmonary edema to the patient. The practitioner should also explain to the patient that reducing sodium intake, stop smoking, and exercising regularly can help manage their symptoms, but it's very important to stay compliant with their medication to avoid reoccurrence. Finally, the practitioner should discuss with the patient and family when they should seek medical attention. If the patient is having sudden shortness of breath, feels like they're suffocating, has bubbling or gasping sounds when breathing, more difficulty breathing with sweating, appears cyanotic, or has new confusion or sudden hypotension, these are times that the patient should seek emergency medical treatment. Following stabilization and discharge, the patient should be referred to an appropriate specialist depending on the underlying causative factor. Specialty referrals should be specific to the patient's overall needs. There are some instances where long-term management may be difficult, and depending on the patient's financial and supportive needs, a social worker or case management referral may be necessary to ensure compliance. Some patients lack transportation or lack financial stability to adhere to care, which can lead to exacerbations and readmittance. By identifying these needs early, proper referrals can be made prior to discharge to facilitate a more linear transition of treatment from the inpatient setting to the outpatient setting.
Practice question 1. A 68-year-old female with a past medical history of heart failure is on your service. While at bedside, the patient suddenly develops shortness of breath and tachycardia. Upon examination, you note crackles bilateral to mid to lower lobe lung fields. You review the patient's labs, BUN of 286, troponin of 0.04, BUN of 18, and creatinine of 1.01. You suspect cardiogenic pulmonary edema caused by fluid overload. What is the first-line treatment for this patient? A. Furosemide, B. Niciretide, C. Nifedipine, or D. Morphine? Answer is A. Diuretics like furosemide is the treatment commonly used to treat cardiogenic pulmonary edema. The use of higher doses are associated with improving dyspnea, removing excess fluid and salt from the body. Practice question 2. The provider can help improve patient outcomes by making quick diagnoses and appropriate treatment plans and starting therapeutic interventions by determining the precise cause of a patient's non-cardiogenic pulmonary edema. The most common cause of non-cardiogenic edema is A. Aspiration pneumonia, B. Acute respiratory distress syndrome, or ARDS, C. Toxic inhalation, D. Near drowning. Answer B. Acute respiratory distress syndrome, or ARDS, is the most Recognized non-cardiogenic pulmonary edema. ARDS is a non-cardiogenic edema caused by secondary to an underlying condition like sepsis, pneumonia, gastric aspiration, blood transfusion, pancreatic multi-system trauma, and trauma to the chest wall or drug overdose.
What diagnostic technique is the most accurate when determining whether the patient's pulmonary edema is cardiogenic or non-cardiogenic in nature? A. An echocardiogram. B. A chest x-ray with posterior, anterior, and lateral views. C. Pulmonary artery catheterization. Or D. Comprehensive metabolic panel. The answer is C. Pulmonary artery catheterization allows providers to measure pulmonary artery occlusion pressures to determine whether the patient's pulmonary edema is cardiogenic in nature. Pressures over 20 is indicative of a cardiogenic cause, while lower pressures indicate the source is non-cardiogenic.
So for practice board question number 4, 32-year-old female presents with sudden onset shortness of breath, wheezing, and heart palpitations. She has no significant medical history, but she's now requiring supplemental oxygen. She's admitted for further workup and found to have elevated tricuspid regurgitant jet velocity on echocardiogram. This raises suspicion for which of the following? A, right-sided heart failure, B, pulmonary edema, C, asthma, or D, pulmonary hypertension. The answer is D, pulmonary hypertension. Elevated tricuspid regurgitant jet velocity on echocardiogram is highly suggestive of pulmonary hypertension. Young females with no pulmonary or cardiac history would be at risk for an idiopathic pulmonary hypertension. Question number 5. We have the same female. She presented the same way and was worked up and had found to have that elevated tricuspid regurgitant jet velocity on echocardiogram. Given the provider's suspicion for new onset idiopathic pulmonary hypertension, what test would we order to confirm this suspicion? A, a chest x-ray, B, right-sided heart catheterization, C, a thyroid panel, or D, pulmonary function testing. Correct answer is B. A right-sided heart catheterization is the gold standard test for diagnosing pulmonary hypertension, so that's what we'd want to order. A mean pulmonary artery pressure greater than 20 millimeters of mercury is considered diagnostic for pulmonary hypertension. Here is our first page of references. Pause if you have any questions on them. Here is our second page of references and the end of our presentation. Thanks so much for listening.